is our Dean for Learning Environment. So I'll let you guys go.
Thank you. Well, thanks for coming, everyone. Our original intent with this presentation was to have a panel discussion. Our panel participants have been very fluid for a variety of reasons. There were people on the panel that you will never know about because the schedules. This is a tricky day to get people to do things. But anyway, I'm very thankful that Evelyn has stuck by me and has joined me for this session, which I think is going to be somewhat illuminating and informative for folks. So we'll get started. If I can advance the slides.
Do we want to say that we want to encourage one-person participation?
I can do that, yeah. So basically what we're going to do is talk about the domain of professionalism, both as LCME and ACGME competency. We're going to, after we spend about 10 or 12 minutes on a little didactic portion talking about professionalism, we're going to give you the opportunity to engage with us on 3 completely different types of cases so that we can talk through the approach to the learner in the scenarios, perhaps consider other types of variations in the scenario, and talk about what resources we have here at the University of Pittsburgh and in the graduate medical education at UPMC. And then we do have a resource document. This is a very old school presentation. We have no animation in the slideshow, and we actually have paper that we're going to hand out to you. This is completely retro experience for many people. We will, however, distribute the resources electronically after this presentation. So thank you for joining us and hanging in there. So let's talk about what are the different models and the ways we think about professionalism, and then what if a learner does in fact have a lapse in professionalism, and what can that predict, and then how do we work with different learners with professionalism behaviors. One of the wonderful opportunities that we have in medical education is that we always have learners at different levels, either because of their chronologic experience through their training, early medical student, later medical student, residents, fellows, even attendings actually, are all at different levels. And also their development through professionalism behaviors. And it's important for us to recognize the professional interactions that we have as physicians versus the human interactions that we have with each other. And this is not always a clear line between the two. So we'll talk a little bit more about that. And then the different solutions that you as an educator have when you encounter, hear about, notice these types of behaviors, and then what sorts of resources do we have here for you. So let's talk a little bit about the ACGME definition of professionalism. Now you may have noticed that I skipped right over the LCME definition of professionalism because there isn't one. That's convenient. I bet we expect our medical students to behave in a professional way, don't we? Right, but unfortunately it's not as clear with the LCME as it is with the ACGME. So, professionalism is one of the 6 domains: patient care, medical knowledge, professionalism, communications, problem-based learning, systems-based practice. Professionalism is one of those competency domains that we talk about. And it encounters several different levels. We actually look at 6 different sub-competencies of professionalism, which talk about the provider's attitude and behavior, treating people with dignity and respect. This is always an interesting thing to consider, how the patient's needs supersede our needs as a provider, which then can somehow get into the burnout and realm and well-being. So that's also very interesting. And then also being accountable not just to your patients and families, but also to your colleagues. So the importance of us as colleagues recognizing that we're all responsible for each other's professional behavior, which really starts to get things a little challenging, especially if it's in a colleague. So those are the types of things that we talk about in the ACGME. Now these are the, this is a very wordy slide, but this comes straight from the milestones for the ones that we use for pediatrics. And this is what we are asked to evaluate and train our learners. And so, and I'm not gonna lie, I think this is a pretty broad request from the ACGME. Full disclosure, I'm actually a member of the Pediatric Review Committee on the ACGME, but we do in fact hope that programs are able to support their learners through these. So we talk about humanism, we talk about professionalism, we talk about professional conduct, and then also appropriate help-seeking behaviors in the event that you or a colleague are in need of some support. And I think the one that's easiest for most people to hold on to is trustworthiness. Do you trust me to take care of your patient for the weekend? Do you trust me to give you a complete sign-out on this patient when I hand over to you? That's something that people, it's easy to understand, recognize, and sort of measure on a qualitative level, I think, I would say. And then, you know, the part of ambiguity in medicine is really about conversations with patients and families and how we work through different clinical challenges. So those are the sub-competencies that we talk about and measure. So who cares? Who cares about any of that? Patients. Patients care about having a doctor who behaves in a professional manner. I wouldn't argue with that. Who else cares? Colleagues, right? I prefer that you treat me with dignity and respect and give me a complete sign-out on the patients that you're handing over to me.
Faculty care.
Yeah.
I'd like the students to behave professionally when they interact with me.
You care about
I care.
students' behaviors.
Yeah.
That's such an interesting thing. And you know, it's funny that you say that because I mean, I feel like every week a student behaves in a way and I was like, ooh.
Yeah. But
Yeah.
you care, right?
Yeah, I care deeply and I have to worry about how to talk about that.
Right.
Well, I'll tell you who cares. Your boss eventually will care. And really, this domain is the only one that predicts future outcomes in employment and promotion and retention and all those things. So it's interesting that it's it's not a standardized test, right? I can't give you a test of professionalism. It's much more subtle than that. But long term in people's careers, this is what's going to really determine their outcome and their success. So there's, yes, Stephen.
I mean, if you're a super lumper, I mean, you could almost say that there are really just two competencies: patient care and professionalism. And I think, it seems like the only one that patients really care about the most is professionalism. That they kind of assume the knowledge part because they don't know what that is, and they kind of assume the skill component because of the training. And it seems like the thing that differentiates whether or not they like a resident or a medical student or feel cared for is the level of professionalism that they experience.
I might counter that communication also is key in those interactions. I mean, so for me, communication and professionalism, right, they kind of come together on a couple of levels.
So, you know, one thing about the medical student level on the AAMC's EPAs, if you go down to they don't list a specific EPA as professionalism, but if you bore down to the competency level, and this is fresh in my mind because I did do this with the National Board
Good for
yesterday.
you. That's why I'm glad people are here.
Yeah, because we're working on some stuff with this now. But if you look at the one about collaborate as a member of a professional team, EPA 9, one of the competencies is establish and maintain a climate of mutual respect, dignity, integrity, and trust prioritize team needs over personal needs. Those are all competencies under EPA 9. So I think what they did is they sort of subsumed it into a bigger EPA, but it's definitely there as competencies.
Yeah, so that's interesting because that is, working within a professional team
Right.
is a systems-based practice sub-competency from the ACGME,
Right.
so that's interesting.
How they, it's a matter of how you slice the loaf of bread,
Right.
but it's still the same loaf, you know?
Right, it is, you know, a physician going to the bedside of the patient, you can't really divide that person up into those different pieces. Okay, so there is some evidence out there that this is eventually important for people's future careers. So the other thing is that the ACGME does also care about professionalism, and I will say that the American Board of Pediatrics cares very much about professionalism in that, and I don't know what it's like in other specialties, but if we have a trainee who comes to the end of their residency training and they have all the medical knowledge and the communication and the QI and scholarly work, but if we feel that there are concerns of professionalism, we can mandate an additional 12 months of supervised training before we, and I know there's at least one person in this room who's been through this with me, before we will approve them to sit for their board exam. So they take it very seriously. So we're supposed to teach and evaluate professionalism and then address recurrent attitudes that undermine professionalism. So I'm going to give you the opportunity to do that. I know you're glad you came. So we're going to present some scenarios for you guys to talk with us about that may develop, which may demonstrate some unprofessional behaviors.
Okay, wonderful. Good morning, everybody. Can you see me if I sit down? I don't know, I feel awfully short.
Yes, I'm sorry, there's a hand on the back.
The question
Yes,
about
Dave.
why professionalism,
Yeah.
for everyone who's been, who's younger than me, which is everyone, if you haven't read Forgive and Remember, which is Kentucky Class book about surgical training, where he talks about the role of professionalism in medical education, he gives the best long description of why, given that we can't really watch people, the one thing that you have to do is trust their professionalism.
Thank you.
What's the name of the book again?
Yes,
It's called Forgive and Remember. It's by Charles Foss. It was probably written in the mid-70s or 80s. It is the best book on why we act the way we do towards trainees.
Okay.
Any questions before we move on to case? We have 3 scenarios, and we're gonna let you manage them, and we'll talk about them as a group. So I'll read the first one. Okay. So case number 1. So AB is a second-year medical student, member of your advanced interviewing group. He does not seem to connect well with the standardized patient or with the other students in the group, and is noted to be texting on his phone when he's not actively interviewing the patient. He appears disinterested and disengaged. You're concerned about his apparent lack of professionalism. So Andy likes to call this, and we're going to quote Andy a lot. We should say that he's actually presenting right now at the Down Syndrome Congress, and that's why he's not here. He's disappointed not to be able to come. But he considers this case really to allow us to talk about the differential diagnosis of professionalism issues. So what do you think when you read this? What comes to mind?
I worry that there's something going on in his life that's taking him away from the small group and being present.
What sorts of things?
So, something bad.
Something bad?
I don't know. You know, something going on in his personal life that he's trying to deal with. Yeah, that's one of the
That's
things
one
on the
hypothesis.
differential.
Right, that would be one part. So a crisis, some family crisis perhaps, or something else, something bad. Carla says something bad. What else might be going on? In the back?
I kind of wonder if he's just kind of clueless, having grown up with lots of
In terms of the technology piece, you think? Yeah. Okay. So clueless. So something bad is one thing. You have to clueless. What else?
He might be depressed or have some other mental health issue.
So maybe that falls under something bad. But something bad with him, something bad with somebody else. Okay. What else? Amr?
You may not buy into the scenario of using SPs.
Mm.
Feel it's artificial, so he's already disengaged.
Okay, so truly disengaged. Okay, so we would probably call that unprofessional. So whatever it is, not buying in. Okay. What else? So something about his interpersonal skills. What else? Okay.
Anxiety about the experience.
Right. A lot of students we know, I want to say the those we get very nervous about having to be able to interview in the simulated session in front of their peers. Right. What else? Tom?
Two kind of almost conflicting things. One is I would have a little bit of question of why did this person come to medical school if their first time to do anything clinical doesn't interest them. The other would be maybe this is somebody that's done a lot of this already and just doesn't really is disengaged because he's had the experience with interviewing maybe he's being an EMT.
That's what maybe he's bored, right? This is beneath me, right? I know how to do this, right? Wow. What else?
Yeah.
It's a lot. It's a pretty long list. We have something bad going on in his life, also maybe something in the family, something external to him. Maybe he's just clueless with regard to technology. This is sort of normative behavior. We're always multitasking. Maybe he's depressed, doesn't buy into the whole SP model. Maybe he has Asperger's or something on the spectrum of interpersonal skills issues. He's anxious about doing this performance. He's just bored. This is just too easy for him. He's been a clinician previously. That's a pretty impressive 1, 2, 3. That's 7 different things going on. Yikes. So all this is going through your head. So you guys are wonderful clinicians and medical educators. You're creating this differential. But certainly this person's behavior catches your eye. And you think all these things could be going on. So what do you do to proceed? To figure out what might be going on. Which of these 7 or more things are going on with this particular learner? Talk to him? Okay. And how would we do that, Dina?
We would just make an appointment to chat and just say, this is the behavior I'm observing. Can you share with me what's going on? I think I'd also like to know how he's been doing otherwise and what other experiences he's had like this. Is this new behavior? And I probably would do that first before chatting.
So how might we find out how this is an MS2, not brand spanking new. It's not the first class in August of the first year. How might we find out how the student's been doing? In other words, what resources do you have as an educator to find out how the student has been doing?
I asked Cynthia.
What's that?
I asked Cynthia.
You asked Cynthia.
I did a lot. This
Oh, she's
happens
not on our research.
a lot because I'm the course director for advancement interviewing, and a lot of times
We have to add you to the research.
I'm like, what is going on with this person? And then I'll ask Cynthia, or I'll ask sometimes the people who work in the SP program, and they know the whole backstory about the student, and then it makes a lot more sense.
So Cynthia is our Assistant Dean for Office of Medical Education. I neglected to put your name on the resource list. Shame on me. So who oversees the education of the MS1s and MS2s? Right. Who else could you ask? Peter, you had your hand up.
Also the advisory dean, may take a little while to figure out who that is.
Aha.
So sometimes it's hard to, because it could be just an off day. You hate to call somebody in the office for that. On the other hand, if it's a pattern and everybody thinks it's an off day, it's much better to have a pattern recognition and address it.
Good point.
And we're not so great at that, I think. So I think both asking Cynthia for this better overview. Reaching a little potentiality in a way, but I think the big for first year.
Because we don't understand the case whether this is the first day of class or the 4th day of class. And that's a good point. If it's the first day of class, you might want to see how the second week goes, perhaps. I'm going to follow up. Any other thoughts? Any thoughts? Okay, Jason?
I guess I just feel a certain pressure to intervene quickly,
Sooner?
thinking about the other learners.
Especially
So
if
I
they're
would
picking up
probably ask the student to put the phone away during class, and then later maybe do a more complete assessment.
So Jason has created for a small group facilitator guidelines, and maybe we should send those out as well to this group. Might be interesting. So the impact not only for this particular learner, but for the people who are noticing this person. What if everybody starts pulling out their phones and thinking, oh, well, that's what we do here. That's now normative behavior. Go back to what, I'm sorry, go ahead, Carla.
I oftentimes, as a course director, get kind of a short list of folks that that have specific considerations as I'm assigning them groups and assigning them facilitators. So usually we just let the chips fall where they may, but there'll be usually between 3 and 5 students every year that I will hand select their facilitator. And I don't know what the right answer is, because I always struggle. Do I tell the facilitator that I'm doing this purposefully, or do I just do my best guess about who's most likely to be able to handle that student well, and then wait and see if I hear about any problems?
Interesting.
And I do up front tell my facilitators that if there are any issues, I want to hear about them sooner rather than later. And I hope then that they'll come to me after the first session or whenever they notice this, and then I fill them in on the backstory. Because I feel a little bit reluctant to color their opinion about the student, because maybe the student will do fine in that environment with the right facilitator.
Concerned about introducing bias and neglect to say, so
Yeah.
which one? So Carla directs this course, the Advanced Medical Interviewing, so we should find.
So my point is,
Yes,
is that,
right.
is
So you
that
don't
you
know.
can ask the course director.
Thank you.
The other person.
Thank
Sorry,
you.
that was a long-winded point. You can
Absolutely.
ask the course
That
director.
should probably be the first
because
person you
usually the
talk to.
course director's right there, and you can ask them,
Right.
hey,
I
do you know
agree.
what's going on with this student? Do you know anything about them?
Probably the first person to talk to maybe after the student. I'll follow up on what Dina said. So speaking to the students, we've heard some general consensus, don't wait too long before damage is done to the student, to the group. It's actually a 4-week course if I remember correctly, so don't wait too long. How should we talk to the student? Is this something, I think Jason said, during the class, please put your phone away. That's part of small group guidelines. How might we approach this individual student? What do you think?
So I make it when I'm teaching AMI, I make it pretty standard that I do one-on-one feedback at the end of the afternoon. And so I would probably say at the end of the session, say, hey guys, I want to meet with each of you guys individually. And when that student comes in the room, I say, I noticed you were on the phone. What's going on? And I usually try to keep it really open-ended and let them kind of tell their story, and try to keep it non-judgmental when I'm asking the questions until I know more, and then I can kind of give it better advice.
A lot of heads nodding. So hopefully the student maybe divulge to you that I'm having trouble, like I'm having a family crisis, my mom's sick and in the hospital, or I was an EMT and gosh, this is just too easy for me, or I get really nervous when you make me interview. I really had a hard time last year in first year. Find out more. So this I think absolutely being done in private. We're likely to get more information. Would not really shame this individual and get really useful information.
Or the other response might be, oh, I'm not allowed to have my phone out.
That's right. That would be the clueless.
That is correct. You're not.
That is
Sorry.
true.
That's right. Did you not read the small group guidelines? Right.
Yeah.
So it allows you to have all these hypotheses going in. It's a chance to, I think, redirect the student in the group, hopefully so that other students are not going to follow suit, but then follow very quickly at the end of their first class, one-on-one, in private. I think that's important, to get information to allow you to test these different hypotheses. And then based on what you find out, what are some, so we mentioned some of the resources, so based on what you find out, we heard course director for one. Suppose it is, so, in a particular order, let's say it is a family crisis, or, so, here's the list your differential was. So family crisis, clueless, depressed, anxious, bored, Asperger's, in a nutshell. So what are some of the resources? Your course director, I think I would agree. I'd be the first person, if I were teaching that class and I came out of the room, I know I do that in the first years. Yeah. Who else? What other resources do you guys have?
Well, someone mentioned
Except Cynthia.
Advisory dean.
Advisory dean, right? And how to find them, so we have a list for that.
The med school has mental health services
Okay,
for
so
students
a lot.
struggling with.
Right.
Good.
Right. We have the name, phone numbers, and email addresses for how to contact. Actually, there's a very extensive mental health support system within the medical school. If you didn't read the New England Journal article, was that last October? Jordan Karp, the school psychiatrist, and Dr. Levine published a lovely paper in the New England Journal about the system that we have. It's all free of charge, confidential to students that don't have to worry about co-pays. We have a psychiatrist, and I think we now have two, we're in transition a bit, two counselors available. There's also the Pitt Counseling Center, all free of charge to Pitt students. So a lot of mental health support. Fast advisors and advisory deans all fall under the school, so under the student affairs office, we have that contact information. Honor Council. We didn't talk about Honor Council. Anybody familiar with Honor Council here? Anybody? I said Bob raised his hand. Cynthia? So let's say this would be more a professionalism issue. Suppose a student says to you, you know what, I think talking to patients is just a complete total waste of time. It's overrated. I actually had a student who said, I don't understand why you just don't put their, why you just look at their x-ray, like why do you have to talk to people? She has since come around and but listen, just don't buy in. I think this, you know what, I'm really not interested. I'm frankly not interested, and I think talking to patients, I'm not, and I don't really care if this is disruptive to the rest of the class. Let's just say that would never happen here. Right? So if that's a student professionalism issue, then there would be something to talk about. It was Cynthia to consider going to Honor Council. They deal with student professionalism issues. And what about SHARP? Anybody heard of SHARP? Get a bunch of nodding heads. Student Health Advocacy Resource Program. This is a peer-led referral source of program for students. So there are 2 SHARP reps per class that are voted on, elected by each class, and they're really the liaisons. Actually, Jason, you're right on SHARP. Am I explaining this correctly? So they're the liaisons. They might say, I understand you're struggling, can I help connect you? Do you remember how to get in touch with a counselor? And really help connect them to services. And this is also confidential.
And how would they find out about the student?
So, and we can talk about that as well. Maybe you want to speak to that.
Yeah.
So the students they can refer. I haven't referred to SHARP. Usually it's peer-led, but I'm going to talk about that, Jason.
There are 2 SHARP reps per class voted on. Everybody knows who they are. There's also on the website, Student Affairs website, a listing. There are also 4 faculty advisors who can facilitate those interactions.
So as a
students self-refer? Do they go to them when they
Yes.
need help?
Yes.
And then Honor Council, we can refer students to Honor Council. Sorry.
So can I just go back to the SHARP? As an educator, is it worth reminding students about that resource, or do they know about? Okay,
Yeah.
so that's another thing.
It's always good to remind.
I mean, one of the things they do if something comes to me or someone in OMED is 2 things. One, let them know that we understand that they may be more comfortable talking to, that they should choose to somebody.
Okay.
Okay, number 1. And number 2, some of them, you need to talk to them about articulating their concerns. Just many of them, for example, going to a course director is a big deal.
Mm-hmm.
And so that's another thing a lot of these people will do. Will try to help people feel comfortable going to a FAST advisor, advisory dean, etc.
Yeah.
One big challenge in this, and I'm just thinking back, all of them in Reed's course, but working with the SPs, I've had a number of students with significant mental health or life crises that it's great to give them these resources, and I'm not sure they're going to go. And then when I tell them that I'm concerned and I want to reach out to their advisor, I want to reach out to their FAST faculty, they say no, don't do it. And I mean, I wonder, I'm sure others have had this experience, and I feel like it just leaves me feeling worried about that student. And I think that happens more often than not. So when you're really worried about someone and you're not confident that the student's going to follow up with these awesome services, what do you do? Because if the student tells me, don't tell my advisor, don't tell the person.
Thoughts? Bob?
I guess I want to separate the behavior that's unacceptable.
That's what I was
from
gonna say.
the reason.
Yep. Very good.
They don't want to get help, that's okay. They need to know they're failing, their behavior.
Yeah, I guess I'm not talking about, I guess when we're doing a differential diagnosis of why someone's not doing the correct behavior, and then you explore it and you find out it's not really a professionalism, it might be undiagnosed mental health. It may be, maybe a student was raped and this case touches on that. So that's where it's hard.
This is where I'm disagreeing with you. I'm still saying the behavior is unprofessional. The reason for the behavior may be remediable, that is, they have a mental health issue. They have to choose to get help for their mental health issue. From my point of view, I can lead them to water. If they choose not to drink, they are still unprofessional.
Yeah,
I just find it hard.
Right, it is difficult. Can I just pick up on that a second? So what I heard Dina say, which is I think one of the most important first interventions, is to basically just hold up a mirror and say to them, this is what I'm seeing, and describe it, the behavior. because that's what it's about, right? I'm seeing this behavior, I'm seeing this performance, and I agree with you 100%. I can say this is not acceptable in this setting, in this class, in your career, what have you. The fact that there's a backstory, right? We're all doctors. It's so great to listen to you guys like dive right in and go straight for what the problem is, as opposed to saying, just put the damn phone away. Right? I mean, it could be that simple.
Yeah, and you wish maybe that's what we should be doing. Maybe we shouldn't be diving so hard.
Well, I think it's important to recognize what you're doing. Reed, sorry, I
I want
interrupted
to
you.
comment about the advisory dean list on that list there. So as advisory deans, especially the ones and twos, are reluctant to have you come talk to us because they know that we help write their dean's letter at the end. And so that role that we play as advisory deans is can sometimes be a barrier to students coming to us as the advisory deans. So when you get pushback from a student, when you say go talk to your advisory dean about that and they say no thanks, that's why.
Right.
And so that's something that we're working on, but especially the ones, because they hear that we write their dean's letter and they think we write the whole thing and they think it's like we have all this power over them.
Dina, yeah, Mike.
So I just want to bring, probably you're going to this, but if this were a resident.
Oh, we have some resident cases. It's perfect. We'll just get that. I'm going to move on in a second. A couple more comments.
I just gonna say, your third reference, Guarasio, in her book about remediation, she talks about how the remediation of professionalism is the most difficult, and she goes into the key is making correct diagnosis. It's just like medicine, right?
Yeah.
You have to make the right diagnosis, and then use the resources you have. And she emphasizes the use of coaches, non-judgmental coach to help get people, one, to make the diagnosis, and two, to get them back on track.
Allie,
It seems like there's only really one reference resource on here that could be seen as not stigmatizing or labeling or something to stick with them, which is this counseling center, which I actually didn't know about. But I agree with Jane, it's hard because I don't know that I would push them if they feel like that's somebody who sticks with them. I just went through this week and the student said, you're right, I need to go ask for help, and he himself went to the course director. But if he hadn't, I would have had to still grade.
Right.
This is what happened. But if he weren't willing to be known for asking for help, the only place he could have gone. I don't see an ombudsman that's separate from our system, is what I'm saying, other than the counseling. I don't know.
Is the Sharp group meant to be type of an ombudsman service or no?
Not exactly.
Okay.
It is for health related, mostly mental health
Okay,
stuff.
you know what? I'm going to move to our next case just for the sake of time. So,
Yeah.
you guys, this is great. This is exactly what I knew was going to happen in this room. Okay, this is a little more straightforward. M3 student, inpatient rotation, presenting a patient was transferred from another facility. The student says, the L&D at the OSH, the outside hospital, did not even do an LP in the ED. I really don't know what they were thinking. So this is not an uncommon thing that I hear.
LMD.
The local physician.
Oh. That's
Just get rid of the acronyms. I'm bad at reading acronyms.
So you're on rounds. This is the case presentation presented to you at the bedside. How do you respond?
At the bedside?
So in front of the
Sure,
patient.
sure. I mean, wherever they do the case presentation. Let's say it's not at the bedside. Let's say it's behind closed doors. Does that change it? That's an interesting comment. Please do tell me, how does that make it different?
Well, if it's bedside, I'm probably doing damage control immediately and like sort of cutting them off and taking over. And then we can deal with it after. If it's in the room, I went to med school here and that's how everyone talked. So I was actually...
Everyone, not everyone.
Not everyone, not everyone. No one, that's true. But that came up the last time I was on boards and I was telling my team, when I was a third-year student, I thought whatever service I was on was the smartest in the hospital and no one else knew what they were doing. Because that's sort of the vibe some of the residents and fellows get.
Interesting. So would you
so I
say...
think this is a learned behavior.
Okay. Well, shame on us. Just gonna let that land a minute. So So do you think that this comment about that local physician is showing dignity and respect for that colleague?
No.
I agree. Do you think this is unprofessional behavior?
Yeah.
So, as the person leading rounds, wherever this comment occurs, what do you do about it? Ooh, this is a tough one, right? Because we all hear this. Yeah.
I think that I would say, you know, I've heard this kind of language before, and I just want to bring our awareness to the damage that we do, because we can't know exactly what was going on in the ER at that outside hospital in the moment that child or that patient was there, and just sort of naming it. I do a lot of work in addiction, and it's the same thing. You just basically name it, and then unless the student is pathological or something, they'll probably get really embarrassed. But everybody on the team will have to own that, because it's not
Because that student didn't come up with that on their own, did they?
No.
They heard that from the
that's,
senior or the
you know,
intern.
House of God, Samuel.
Absolutely.
You know, yeah.
I think this is happening all the time in different ways, so I think just very fast, being very transparent, reframing it, and not even having to point a lot of direction to it.
Right.
But I think the more that we are reframing those kind of behaviors, the more it's going to be ubiquitous in the team, I hope. But you're right, it's everywhere. So that's something that whether at the bedside or in the room, I'm going to reframe pretty fast.
So does a student own any of this?
I'll be watching the student and listening. I don't know if I would.
I mean, the student absolutely heard that from the residents.
Mhm.
There's no way the student came up with, on their own, the idea that the LP should have been, you know, that's absolutely on someone else on the team.
Right.
And so you want to be careful.
Harping on the student.
Right, you don't want to,
If
you
they
want
got
to
it.
like, you want to sort of think that, you know, wow, here at UPMC we have all these resources, and you may have never worked in a community hospital, and it's very, you know, it can be very different there. Isn't it good they sent the patient to us, you know, and just sort of, but make sure that, I would probably actually talk to the intern and resident on the team rather than the student about that comment.
Yeah, and I was hoped that you would get to that point, is that the students are sort of passive learners in this situation. Mostly. They may have owned some of this. I mean, maybe that student's an EMT from another life.
Yeah.
And does have preconceived notions about how people should behave in EDs.
So I'd be a little careful to be sure that the student has never heard that from the attending.
Very good.
Yeah.
I have definitely said stuff like
Yeah.
that before. I've never said that.
Ooh, isn't this uncomfortable? I wish you all could see your faces. It's so
Experience for me.
Where did we learn it, right? It was modeled for us.
Even if we don't say it, the fact that we repeat every fortune test that has been done in the outside hospital.
Every what?
Every test that has been done.
We don't trust.
Shows that whether we say it or don't say it, we don't trust anything that isn't done within the 15213 area coverage.
And sometimes we members of other UPMC departments, right? Is each other,
Oh, sure.
right? So we do it here.
So this is a little more uncomfortable, right?
The other thing that I might do is own it as well and say, you know, I also, you know, I'm sure that I do things like this too. And we just a reminder for myself and all of the team, we need to kind of make sure that we're not disparaging colleagues and others, because we really don't know what it's like to be in that situation.
Unless you've been in that situation. Unless you've been that LMD.
There's something else actually that if it happens on the bedside and you sort of soften it a little bit, comments from the patients that say that I'm protecting other doctors because they may have felt mistreated in the other hospital, whether true or not true. So you have to sort of, on the bedside, be very careful how you proceed with this too.
Yeah. I mean, I had a conversation last night with a family that was transferred down from another facility about how they've had it with that hospital, they've had it with that ER, or they're only coming to children, and I was like, well, they actually didn't do such a bad job. Anyway, So, and I shared that, well, they got that CT scan that showed that huge diffusion. That was really helpful that we don't have to repeat now because we already have the information. So, we listed some resources to consider in this case, but I think we can all recognize that a lot of these behaviors may not necessarily require outside intervention, but more internal intervention. The other thing that I wanted to add, and I wanted to put a plug in for Evelyn's, in the event that there's some concern that faculty or residents are modeling unprofessional behavior, the students have a way to report that. And then we, in the residency program, as I know Dean was going to talk about, we have, resident fellow assistance programs in the event that we feel that there's malignant behavior. This is a little more, I think, ingrained behavior and much more difficult to sort through, but I would encourage you all to always think about treating everyone with dignity and respect, including our colleagues that we never meet. So that was.
Can I make so the PAIR website, so most often students make those reports, but anybody can actually enter those reports. When we created that a few years ago, it was designed that a nurse could say, Dr. Painter's fabulous, I want to give him some accolade, or whatever. So anyone within the system, you don't need a password or anything. You can enter information and enter reports. So the more use it gets, I think that would actually be beneficial for us as a system.
So I think the one of the points that we wanted to highlight in this case is that these conversations can sometimes be really uncomfortable, not just because of the behavior that's being displayed, but because of what we or people like us may have contributed to the behavior. Yes, Dina.
It just strikes me that this is this kind of behavior and the thinking that underlies it is kind of like the unconscious bias and the resulting microaggressions, and shining a light on it in as sensitive a way as possible, becoming aware of it myself, and then sharing the responsibility among the team and calling it out in an appropriate, sensitive, and hopefully effective manner is what we have to do for all of this.
Yeah, it's all of our jobs, right?
Thank you.
My pleasure. Thank you. Okay, let's go to another scenario. This is with a resident. So PGY2 in the program had a crazy night. Puts a picture of the ED board on Facebook. This is legit. This really happened. Saying effing crazy here tonight. Ooh.
With patient names on the ED board?
So this person was crafty enough to recognize that would have been a HIPAA violation. Right? So all you have, the names are over here, so the picture is over here. Labs, bed request, all that kind of stuff.
This sounds like a real case.
This is legit. This happened. So what do? You're a friend of a friend on Facebook and you see this. Reed just came to me with something on Facebook this morning. Fine, it's nothing bad. But I'm saying, you see things on Facebook. What do?
I've actually uninstalled Facebook.
I'm sorry?
I've uninstalled Facebook.
Okay.
That's one response.
So it sounds like avoidance.
So
Instagram, Twitter.
it's interesting because UPMC has a policy about
They
this.
sure do.
So that one, I think I would talk to the program. I mean, I would talk to the resident, but I think
What would you
that'd
say to
also
them?
I would remind them of that, and that that one I would just actually talk about how we are professionals, and now you're a part of a professional society, and you need to be cognizant of what you're saying.
So what should I do as that resident? What are you going to tell me to do?
It's freedom of speech, right?
Take it down.
Yeah.
You have to
It's
take it
freedom
down.
of speech.
Freedom of speech. So this is very
If
interesting.
you sign up for Facebook, you read, I guess, lots of different things.
So, yeah,
If you open it up and you read it, it's up to you.
I think if UPMC saw this, if UPMC HR got involved, this person could, they could take disciplinary action,
Yeah.
maybe even fire.
They could be
residents for
dismissed.
this.
If you read
So
these,
it doesn't matter if the place is identifiable. It doesn't
Yeah,
matter
and-
if it's UPMC or whatever the place is actually identifiable.
Yes, but if it is identifiable, they could
Right.
could technically, I think, take disciplinary action and
Yeah.
fire the resident. So I think I would, my initial thought would be protective for the resident,
Sure.
and then
In what way?
emphasize the severity of this. Get it off of Facebook.
Yeah, take it down. So it's interesting, you're concerned about freedom of
but,
speech.
But then talking about how, that they could get fired,
Yeah.
this type of stuff.
Stephen.
I mean, at first I would, I'd say, thank you for not putting patient names on there. I mean, I would recognize the fact that there was some intent to maintain something. And I wonder, well, what if the exact pictures there were just kind of the list of the craziness, and the quote is, fantastic opportunity tonight to take care of lots of sick people, feel like we're doing some good work. Is it so much the words or the picture? Because if the words kind of boost up the institution or say something positive, it's really not likely to draw the attention.
I feel like I'm on this slippery slope here.
Because I would be surprised if it was, if the same picture as you describe it is filled with words about meaning and how challenging it is, and this is really why I'm in medicine. It sounds like it's more the words that are associated with the picture, the actual picture itself, that makes people anxious. So that actually, the picture is not the problem.
Yeah.
I have the user policy right here.
Here we go.
Oh, yeah.
No, go right ahead.
And it just says, UPMC reserves the right to remove any blah blah post graphics that is libelous, defamatory, disparaging, and then another one is uses harsh, obscene, hateful, or threatening language.
It's the word.
So the
But it doesn't. Wait, about what?
The issue
They,
is
they
it's
can't
nebulous,
remove
right?
anything that they want that,
It's
that
nebulous
falls
and
under
it's
that
social
category.
media, so it's a moving target. So we all
It has to be
recognize
about
that.
UPMC though, sorry.
Yeah.
It just says UPMC employees are bound by the UPMC social networking policy, and any posts that do not meet these guidelines are subject to removal.
And then the other thing in terms of what to do as a program director, it might just be that the person doesn't know that there's a
Absolutely.
policy or the
Put your phone away.
expectations, so-
Don't put stuff up like this on the internet. I mean, there's a
Like
policy.
it might be a one-time thing, and
You
they
may
say,
just
"Oh no,
need
I
to
didn't know,"
educate
and
them.
It never happens
Yeah,
again.
maybe
but
that's simple.
That way, there's some memory.
Sure, Alan.
This is less ambiguous to me because of UPMC policy.
Exactly.
Than if I actually missed that it was an ED, that the student was in the ED, or resident was in, I thought they were like out drinking and posted, oh, it's out crazy tonight. That actually is harder for me because that's not is that a policy violation, or is that just not how I want my resident to be
Sure.
reflecting on the program?
Right.
Because in their bio, they're a
Right.
resident.
Sure, exactly. So, I mean, I think that I will tell you this. I feel like this has all happened in our program. It's just either it doesn't happen in other programs or you just aren't telling me. But when things like this happen in our program, we use it as an opportunity. This is a time that I will talk directly to that resident, but then I'll send that policy out to the entire program. Hey guys, just want to remind you, there is a policy here. Want to read through this, the social media policy, so that everybody's informed. It's a slippery slope. I get it.
But again, this is a really evolving area. I mean,
Sure.
we may not, but the residents live on social media.
Sure.
And so what was unacceptable in the past has now become acceptable. We have physicians advertising their practices on social
Sure.
media, and so the residents are exposed to maybe something different than we are, and that policy is intense, intently kind of vague to accept that those shifting.
I think the other thing to recognize is that patients and families live on social media. So if you have a sick child and then you see this random post like it's a crazy night at children's ED, I'm not taking my kid in. My God, what's happening there?
Also the case that their next employee is on social media. I view this largely as just an opportunity to say, do what, here's what the policy is, say what you want to say, understand that it may have these implications for you down the road. If you don't care about it, you get to make your own decisions with the freedom of speech. Just
Exactly.
remember that, at top, they may look at this before they hire you.
Right, exactly. So we are going to start to pass out these resources. And once again, this is paper. It's very old school. I can assure you, Evelyn, there's 25 copies there.
I know,
And
she
there are
tried to
29
count.
people in this room,
Okay, yeah,
so
right. So don't count.
do the math. Somebody's going to do that handout.
We'll send out electronic
But we
version
will-
updated with the small group guidelines and with Cynthia's contact information. Sorry.
Yes.
One other thing, about the Honor Council and what it does, the Honor Council very, very commonly uses this idea of that maybe people didn't know. So an individual does something, commonly the response
Sure.
is, let's send out something to the whole class.
Exactly. Education is power, right? Let's just be transparent about expectations.
So is it possible to graduate from medical school or to get to medical school and never be told to put your phone away in a classroom, in high school or college? I find
So
that
it's,
hard
so
to
isn't
believe.
that an interesting question? Because, I mean, I don't know what your little small group guideline is, but I did a population health thing with a bunch of second years. And it was a root cause analysis about this horrible case that happens with this woman with the epidural. Can you tell me something? It's unbelievable.
Steph, would you repeat the question? Some of us didn't hear.
Yes, so the question is it possible for a medical student to get to this level of training and never been told to put your phone away? So I don't know the answer. So my response to you is I was in a room with 9 students. Half of them had their laptops open and the other ones all had their phones in front of them. And I had handouts on paper. And so I introduced myself and I said, great news. For the next 2 hours, we don't need any electronic devices, so let's put those all away. Oh my gosh, the level of the systolic blood pressure in the room went so high. I said, no, seriously, there's nothing you need to look up. It's all right here on the paper. So finally, they put them all away, and so I thought the same thing, like, seriously, have you never been told to put your phone away? I don't know the answer. I mean, you know, the odd thing is that every year I get older, and the students are, I feel like,
Younger.
yeah, exactly.
No,
But I mean, their experience is different than ours, right? We're all having a different experience. I mean, there's learners in this room that are younger than I am that have had a different experience.
They've also, just again, play devil's advocate, they've also all had the experience, either themselves or their peers, where somebody posted something on Facebook and got in trouble for it. You know, and you know,
Maybe.
as Bob was saying, that, you know, you can post whatever you want, but there's consequences to the post.
Sure.
I think they've been exposed to that information before they got to medical school. I mean, maybe they didn't listen, but I don't think we're uniquely telling them something that.
Well, repetition is the key to learning, right?
Although, you know, in terms of the UPMC policy, the only reason I know it exists is when it came up in the context of a resident doing something. I didn't know it.
So somebody
any
used
kind
that
of HR
opportunity
training,
to educate
so
you.
They may, you know, I think there's some stuff they may not know.
And I think some people are suspicious about the UPMC policy because they feel like it is designed to quell any criticism of UPMC, and so are, you know, feel like it's a tool to squash
freedom of expression.
Well, and legitimate people who have legitimate rights.
Sure.
Patients, you know.
Sure. Sure.
So we have about 5 minutes, a little bit less than 5 minutes. If there are other questions or comments, one thing I would, if we want to, a couple points about the phones. I have a student committee talking about learning environment, and we reviewed the draft small group guidelines. The issue about putting the phones away, and created a lot of discussion. And I think what I'm coming to realize when talking with the students is that cell phones are not always bad, and putting them away is not always the right thing to do. You may need the phone. I may pull it out in a visit. Like I had to look up the Educational Law Center the other day. It was easier to pull out my phone than try to get through the UPMC firewall, as an example. And so we tell the students that we're teaching them professionalism so that they will be professional physicians. And there are times that they are going to need their phone appropriately. So what I talk to them about is transparency. Whether you're on rounds so that your attending doesn't think you're ordering lunch or making a date or something. Same way you don't want your patient to think you've now lost interest and you're just pulling out your phone to check your email, to be transparent and say, I'm going to look that up for you. Let me see if I can't get that phone number. Or if you're on rounds and the attending is asking a question and the student says, oh, I can pull up that reference, or let me check that drug dosage. As long as they say what they're doing, then it becomes much more acceptable. And that's the kind of behavior regarding phones that they need to show to patients. That's one experience I've had. Other thoughts? Any more comments about technology? Because that's not going away, and there are appropriate times to use and not to use phones.
That's become an issue with electronic prescribing of opioids, because my phone is basically, not that I prescribe that much, but I feel like it's always out, like at my cell box, and I actually am very conscious about saying this is what I'm doing with it.
Right, I think being transparent.
Yeah.
Other thoughts?
I think one of the other things about phones is if you have young kids, or if you have kids, you're not going to want your phone, like you want to have access to you if there's a need for that. And so that's just, once in a while I'm with a patient and I see a phone from the kid's school or something, and
I'll say, I'm sorry, my kid's school is calling.
When
Like,
you-
as a professional, it's
Oh.
very.
You're, as a person,
Yeah,
right.
that's a really interesting point.
And when you get older, your parents, you know, I get a call from my
Yeah.
parents' doctor. I'm like, I
Right,
need to
that's
take
something
that.
like, you know.
Yeah.
So we
you know,
think.
it's sort of interesting.
Right.
Yeah. And I'll say that
We're
things,
not-
I'm sorry, my kid's school's calling, I'm gonna step out for a second.
And they
You
probably
know,
would
I feel
understand.
bad, it really is not professional. On the other hand.
But you're a person.
that's interesting.
That gets to the humanism, right? We're also human, right? Other thoughts?
Yeah.
Stephen, I think it's just very relevant thinking about your first case, because I had a patient that I referred to a physician here, and they came back and were very upset. So the doctor was texting on his phone. I said maybe they were using the phone to look up information about human information, and she said, no, I peeked around. It was just texting. And I thought, well, maybe they were having a bad day. I had another patient a couple of months later. I sent to the same person, came back, same complaint. And so I don't really refer to that person anymore. I use them in the hospital. But that seemed like a pattern. So I thought that the first case was super relevant because it seems to be happening. And this person is not a young person.
So it reminds me, there could be another whole hour or more talking about professionalism and how you address professionalism of your colleagues.
There
So
you
we're focusing
go.
on our learners, but sure, we model. I think what Steph said, right, shame on us. We are modeling all the time. Actually, we're teaching, especially when we don't think we're teaching. And right, we're being watched all the time by our learners, so we need to be very aware of that and to own it. I like that point.
So I think this is interesting because the hospital is moving toward a two-way secure text
Yeah.
messaging.
Yes, well, we
And
have it.
I love it, and I actually I told my team this is the way we're going to be
Right.
communicating about patients.
Right.
But I've had to be very conscious and say, if I pull my phone out, it's because I'm answering a page. It's not because I'm texting.
Yeah.
Right.
But I didn't. I was very conscious of it when it happened because I was like, oh wait, I don't usually pull my phone out. So we need to move toward explaining it better.
Transparency.
Yeah.
Yeah. Yeah. Well, I appreciate everyone coming. I feel like we could go on for another hour at least. Thank you.
Wonderful.
Thank you very much.